We have a 60-year-old male that presents to the emergency room confused. He was brought by his daughter. She found him on the floor of his living room, mumbling incoherently. The patient's history is remarkable for hypertension and diabetes mellitus type 2. His current medication includes metoprolol, captopril, and metformin. The labs show 1,240 mg per deciliter glycemia, a BUN of 40 mg per deciliter, a creatinine of 1.5, and sodium of 130. What is the best next step? We administer insulin, an IV normal saline is administered, a hypertonic saline is administered, or we perform dialysis. We have to consider the fact that he's a 60-year-old male and he has type 2 diabetes mellitus. As we can see, he's on metformin. This is the first line agent for diabetes mellitus type 2. It means he's not insulin dependent, so he's still able to make up some insulin. In consequence, there are no beta-hydroxybutyrate and acetoacetic acid produced. This diabetic ketoacidosis presentation is usually seen in patients with type 1 diabetes mellitus. In contrast, patients with type 2 diabetes mellitus have hyperosmolar hyperglycemic state. In the case of HHS, insulin is not useful as there are still a small amount of insulin made by the pancreas. However, the patients are dehydrated, so they require an IV normal saline. The correct answer is B. The best next step is administering IV saline, as the patient not only presents with hyperglycemia but also with prerenal azotemia. His current confusion is caused by severe dehydration due to HHS. Insulin is not useful in HHS. Only the insulin-dependent patients, such as patients with diabetic ketoacidosis or with diabetes mellitus type 2 requiring insulin, may benefit from this treatment. We have three types of azotemia: prerenal azotemia, renal azotemia, and postrenal azotemia. In this patient was prerenal because we had fluid loss due to hypovolemia. There are three types of azotemia. The prerenal azotemia is caused by hypovolemia, which can be caused either by dehydration, as in the previous case, or hemorrhage. It can be caused by third spacing. In the case of liver failure, we have ascites, or by decreased perfusion, such as in congestive heart failure. Renal azotemia is caused by glomerulonephritis, acute tubular nephritis, acute interstitial nephritis, embolic disease, and rhabdomyolysis. In the case of postrenal azotemia, frequently we have obstructions, nephrolithiasis, BPH, congenital obstructions, or pelvic tumors. The squamous cervical cancer is usually the one that invades into the ureters and is frequently tested on NBMEs. The fractionary sodium is less than 1% in prerenal azotemia, is more than 2% in renal azotemia, and can vary between 1 to more than 2% if it is severe in postrenal azotemia. The BUN to creatinine ratio also will indicate what type of azotemia we have. A BUN to creatinine ratio of more than 20 to 1 is a prerenal azotemia. A BUN to creatinine ratio of less than 50 to 1 is indicative of, and it is variable in postrenal azotemia. For urine osmolarity, we have greater than 500 milliosmol per kilo in the case of prerenal azotemia. We have less than 350 milliosmoles per kilo in renal azotemia, and we have a variable value for postrenal azotemia.